You're listening to Aging Uncensored.
All right, good morning. Welcome back to Aging Uncensored, the podcast where we unpack, unfold, untangle, we might tangle a little bit.
Yeah.
Everything aging, caring for your loved ones, caring for yourself. We might even throw in raising some kids, helping family members, all things. We're going to go off script today. So I'm your host, Christy Baines, and today's co-host is Shaylee Lawson.
Hi there.
And our production, of course, is Taylor Crane in the house. We may have our other co-host, Lady Baines, might walk around or bark in a moment. It's been a while since we've been in this setting. So, yes, this is filming in January. So we've got all these great ideas for what's to come at the beginning of the new year. And that was one thing we were going to kind of talk about first is, you know, you're in the middle of Christmas parties, you're in the middle of all the rush and everything else. Yep. And what are some things right now you're thinking about that, you know, you might want to do a little different or add to your mix come next year?
Yeah, I think this is such a busy time of year and it's super fun, but I'm already thinking about ways that maybe I can slow down a bit in the new year. Maybe just be more mindful and in the moment. You know, that kind of stuff. I know it sounds sort of cheesy, but like,
I love it.
You know, like just not every weekend has to be jam-packed and things like that. That's I say right. That, and I have small children who have agendas, but.
Well, I've decided I'm going to go aggressive and go all in. You know, it's New Year's resolutions. I think I'm going to journal in the morning and in the evening. I'm going to take 45-minute Epsom salt magnesium baths at night to get all the cortisol levels down. I did hear that face dunking is something you should do. Right now on my Instagram feed is all perimenopause things.
Oh,
they say if I ice dunk and do the gua sha, what is that? Gua sha?
Oh,
that
yeah.
stone thing. Nicole would know it immediately. You and I are like,
I know what you're talking about. I think I've seen it.
It's going to come on your Instagram now.
Yeah, right.
But apparently if I ice dunk twice a day and do all these other things, by the time spring break comes around, I'm going to look like I'm, 32.
That is absolutely true. And it's scientific and evidence-based. So absolutely go for it.
And I also think it's sustainable.
For sure.
Okay. All kidding aside, what we all need to commit to maybe one thing, right? I'd like to think of one thing could make a habit. If I can make it a habit by March. So last year, probably the habit that Alan and I made was getting up, getting out first thing in the morning and walking the dog.
Yeah.
And for the most part, I mean, it may not happen every day, but for the most part, it's been pretty consistent.
Yeah.
So I'm like, if I can pick one thing next year to kind of get going.
Absolutely.
I'm not real sure what that is yet.
Yeah. It's okay. You don't have to know on maybe it's December 31st.
Maybe it's face dunking.
I will say, little plug here.
Okay.
I got one of those like cool little ice things from Amazon that, you can roll under your eyes in the morning and all of that. And I just burned my face, like ice burns all over. So I don't know. I would recommend.
Did you make it too cold?
I don't know. It's just frozen water. It's just ice, So maybe do how like if you're going to use a new cleaner, they say test a small area first. I would recommend doing that before doing your whole face. So
that's a good idea. Before I come with like 3rd-degree burns and I'm screaming, Shaylee, help me.
That's right. Yeah. Just be careful.
We all need your skin regimen. You always look so beautiful.
I don't know. There's makeup too. So.
Oh, well, that's good. Absolutely. So we've got some really big projects coming down our way.
We do.
Let's see, I've been courting you for about 2.5 years,
and
then we landed the big project, and here we go.
Yeah.
So I was impressed when we did the podcast together and we were introducing you. You were able to like just read off what GUIDE is. It took me about 7 months to finally memorize what the acronym stood for. I wanted to like make every little thing something.
I think it's because it's like one acronym in my life that makes a little bit of sense. You know, most of them are so wacky, I feel like, and this one makes some sense. So.
Okay, I like it. So
Yeah.
we're jumping into guide,
Yep.
which is,
Guiding an improved dementia experience.
what does that mean? We're still learning, right?
Yeah, we're still learning, and I think we've learned that everyone's still learning that, which is reassuring. But essentially what it means is we're going to be able to offer resources and support to this population who historically has not had a lot of resources and support.
Right.
Which is so exciting because we've been caring for these caregivers and patients for many years now and seeing how they suffer, and seeing the lack of support and the lack of knowledge and just how helpless a lot of them have felt. And so it's really exciting to see that we're going to be able to hopefully give them some hope.
I love it.
Yeah.
I love it. It really is. I mean, especially that we've been doing this for a long time and see where we were. To us, it's common sense.
Right.
We should have
That's
been
right.
doing this all along.
Right.
But, you know, if you're not doing a procedure or giving a pill or something like that,
Right.
this is not, you know, sexy, if you will, in the medical field.
Yeah. There's not any like groundbreaking science here.
Right.
You know, it's a lot of just common sense, which
Right.
is what we appreciate.
Now, it is evidence-based.
Absolutely.
Of course.
Absolutely. Right.
And you know what's cool is Dr. Powers, Richard Powers, who's been our mentor, advisor, all things extraordinaire in helping us with guide and dementia care for years. He sends me all these articles, and we'll do a deep dive with him at some point. But he's sending me all these latest and greatest articles from, you know, whether it's JAMA or, you know, the Gerontological Society or any of those big medical journals. And it's all evidence-based of what care management can do for the family caregiver.
Yeah.
And I was talking to him about it, and he said, you know, it's been hard for them to have this type of research study in the States because we are very diverse. It's complex, you know, we're spread out. There's so many different things. But a recent article he sent me was one that was actually done in Germany. And it was cool because they could really follow and track because it's, you know, everybody kind of lives closer. It's a smaller demographic platform to actually, you know, do the study. And lo and behold, when you give family caregivers resources, their mood improves, their quality of life improves, and the health of both the person living with dementia and the family caregiver improves.
That's right. That's wonderful.
Yeah. Yeah. I mean, because what we see all the time is the family caregiver, their health declines.
Absolutely.
And they sometimes die before the person living with dementia.
That's right. That's right. Yeah. It's not uncommon for us to see that. And, you know, obviously it's heartbreaking. So, you know, when we know better, we do better. So
I love
we're going to get to do better now.
That's right. I love it. We've got all our mottos. Dr. Powers was dream big, do big. If we know better, we do better. Those are really easy ones. We should have those over our office, you know, like a football team, like hits the locker room when they're leaving the stadium.
Yeah.
We need those right there.
Absolutely.
That may be part of our, get on our website at some point. Or maybe
there you
it's just something internal for us.
Maybe so.
But so what are the basics? What does this look like? So I think the first thing is walking through what's been a typical experience.
Yeah, sure.
So yours is going to be a little unique because obviously you had more resources at your fingertips and more knowledge. The clinicians had more knowledge like you at the geriatrics clinic. But what's a typical experience for somebody? You know, and most people don't have access to the brain aging and memory clinics and things like that. So what do you think a typical experience for someone whose loved one's been diagnosed with dementia, they're on in their journey, family caregiver, what does that look like?
Yeah, I'll say I think that, you know, we know that in some dementias, changes in the brain take place many, many years before we actually see changes happen with the individual. And so oftentimes those individuals will be brought to a clinician when something big has happened.
Right.
And something big may be, I've had patients before who were scammed by princes in Africa and had paid hundreds of thousands of dollars and things like that. We've had patients before who got lost driving to the grocery store, and their son who lives out of town doesn't know what to do and how to get mom home, and like just all sorts of sort of big things, you know. I think that families and patients too can kind of ignore small things for a while, you know. Oh, mom may have forgotten one thing, or maybe, you know, she didn't make that cake like she usually does exactly the same way.
Isn't that just part of aging?
Yeah, that's just, you know, she's getting older, and certainly some of those things absolutely are. And sometimes we see patients like that too, but a lot of times they were coming to us with family members because something big had happened. And oftentimes the patient was embarrassed that it happened, or, you know, it doesn't make sense. Defensive. It doesn't make sense to them either. You know, you have to, there's changes going on in their brain that they may not be aware that, you know, they don't have the insight to say, I have dementia, but certainly they have awareness to think something's wrong. Something's not quite right. Right. Oftentimes. And so oftentimes when they got to us, there were already so many pieces of the puzzle that we had to kind of put together to wrap support around this family. You know, they may still be driving, they may live independently, you know, and so it was very, we were reacting a lot to what had happened and not in a position at that point to be able to plan ahead often. Right. And so that was really challenging. And
what were the families thinking? Like, you know, they're coming in and
yeah.
Was it most of the time they're looking for a magic pill?
A lot of times, yeah, they would like to have something to bring their memory back or to make them how they used to be. And, you know, I think pharmaceuticals have made big advances in the last decade, but, you know, there's not anything that's a magic pill, unfortunately.
No, not for dementia.
No. And so, so it was really challenging when you're faced with, it's much more when you're planning for patients who have dementia going forward. It's not as it would be in like cardiovascular disease. So if you have a heart attack, let's say, and they put you on a statin and maintain your blood pressure and your blood sugar, and you know, the outcomes can be very good, and you can improve, you know, your heart function, you can
prevent another heart attack,
modifications, you can do those things. It's not the same with most dementias. Okay. So most of the time when patients are coming in and they've got Alzheimer's dementia or Lewy body dementia, you know, it's not the same as where we can make modifications and improve things. It's much more about planning for the future as we know this will decline, and what does that trajectory look like, and how do we prepare the family for that and the support system for that. Right. And it's individual to every single patient. Every single patient is different in the way that their trajectory is different, and then their support system is different too. Right. So,
and typically though, when they're going to maybe a primary care physician, it was one thing when they were going to the geriatrics clinic because there were resources there. But when you're going to a primary care physician and those primary care physicians are bogged down with everything and then some, there's really nothing. They're not going home with anything tangible. They think it's supposed to be a pill. And particularly if you're in rural areas or areas where you don't have a physician presence that has made a focus on working with older adults.
Absolutely. Absolutely. I mean, that's a huge challenge. Yeah. I mean, it's just it's a huge challenge.
It's like the emergency room.
That's right.
They have no idea what to do with them.
No.
And it's not their fault.
Right.
You know, they're dealing with trauma and just the number of different things that come in, not to mention the people that use the emergency room as a dock in a box, you know, so you've got all types of patients that are coming into an emergency room.
That's right.
And when you've got the person with the dementia, you're either wanting to get them in a bed because they need a bed, or you're wanting to get them out.
Right. Exactly.
And there's really nothing to take home.
Absolutely. It's very overwhelming. I mean, the plain and simple, our healthcare system is just not designed for older adults, or really much less adults with dementia.
Right.
I mean, it just isn't. It doesn't meet their needs.
Right.
And so I think that's what's so exciting about Guide is that we're going to have a program where we can help augment some of that and help.
Absolutely. So I'm going to dive into, so one of the things, and I'm going to get back in close to my mic because I was putting my glasses on. Taylor gave me the side eye that my voice was going out. One of the things that we had to do when we were applying for Guide is show that there are 9 domains, I believe. 1, 2, 3, 4, 5, 6. Yeah. 9 domains that our organization or our team had to be able to provide. And if we couldn't provide some of those things, I think you had to show that you did at least 6 or 7. So you could outsource maybe 1 or 2. In our situation, we're outsourcing 1, and that's actually the last domain that we'll get to. So what's really cool about this is in the beginning, as we're getting the word out there to primary care physicians, neurologists, psychiatrists, emergency room docs, you know, first responders, all the people that see dementia in the moment, you know, real time. And a lot of times these people haven't even been diagnosed, right? So
absolutely. Yeah.
We have this opportunity to do, we'll really be pre-screening at first, you know, and that's working with their physicians, working with the family and so forth, and going through a couple of different things. So there's 2 tracks, if you will. I mean, there's different levels, but the main 2 tracks is the person living with dementia. And then there's another track of the person living with dementia that has a family caregiver. And it's the family caregiver, they're going to define it as the family caregiver that's really having to adjust their life and schedule, you know, take off work, not work, those kinds of things, or the person lives with them. And that's really defining the family caregiver so that they can have access to respite services, which is cool. So in the beginning, we're going to be screening them, and we're determining kind of where they are in their journey with dementia, kind of what level they're in. And if they have a caregiver, we're going to be exploring also the stress and where that person, there's a survey called the Zaret caregiver burden. And basically it's looking into how is this person doing? Right.
Yep.
And when you and I talked to the Amy.
Shout out to our folks.
Yes. Shout out to Emory. Thank you,
were so
Emory.
gracious to meet with us and give us some tips and tricks. They've been doing this program for a while now, so we're really lucky to have them as a resource.
Absolutely. So sidebar note, there are 400 organizations approved nationwide. There are 3 in the state of Alabama. We're one of them. There are 17 between Tennessee, Alabama, Georgia, Florida, Panhandle of Florida and Mississippi. And Emory was the only program that was approved as an established program because they already had a dementia specific program through their organization. And they were so generous. You were able to connect with them via a friend. And what we learned is that they're learning as we go.
Yep.
But she also talked about how she's learning to really give that Zaret burden caregiver survey, you know, because you want them to share.
Right.
You don't want them to go, how's it going? Oh, I'm fine.
I'm fine. Yeah. Because that's what everyone's going to say. That's what we've been trained to say.
That's right. That's right. Especially in the South.
That's right. That's exactly right.
That's right. So, you know, really diving deeper into where they are. But once we get that information, and then they also have to be a traditional Medicare beneficiary. So if somebody's on an Advantage plan, they won't meet this, they won't be approved for this program. However, we're working on things that we might can help patients in other ways.
Yeah,
But
absolutely.
if we're strictly talking about guide, it is for traditional Medicare beneficiaries.
That's right.
They live at home or assisted living, memory
Or
care.
memory cares. Okay.
Yep. Can't be in a nursing home and can't be on hospice.
That's right.
So we're asking them and teasing out those questions. You know, one thing when we were talking to Amy, it's like, so tell me who is coming to help you.
Right.
And they may say, I have a nurse that comes. And then that'll be kind of our flag to say, what kind of nurse?
Yeah, that's right. Because some people aren't always aware that, there's a lot happening, a lot of moving pieces. They may not know that they have hospice or, some other
Maybe they're on
service.
home health, and home
Yeah.
health is fine for this program.
Right.
But if they are on hospice, then they wouldn't meet eligibility for guide.
But certainly if, dementia can last a long time, and we know sometimes patients who are on hospice services for dementia, sometimes they can be discharged just because they're very stable, which is a wonderful thing.
Yeah.
And at that point, guide would be a great opportunity for those patients, because historically there hasn't been much to offer those patients in the setting of care once they're discharged from hospice. So,
and that
that's
is
an
difficult.
opportunity.
I'm so glad you brought that up, because when we see that, and it usually is the patients with dementia.
Yeah.
When you see that, it's heartbreaking because they've had all these resources.
Yeah.
And now they're pulled from them.
Right.
And the
It's so
family's
hard.
like, what do I do now?
Exactly. It's so hard.
You're like, well, you helped us so much that we don't need
Yeah,
you anymore.
I know.
That's
It's
difficult.
It's a really tough thing. So excited to be able to provide those folks with some resources that they deserve.
Absolutely. So starting with the domain. So once we have them aligned, and that's the process we just talked through, is making sure they meet the criteria and they will be aligned with Medicare. We schedule a comprehensive assessment, and that assessment's in the home. So that's what's cool, is we will be going to them. We will be seeing them in their environment, which we know from being private care managers for a long time, and from being house calls and everything and hospice, everything that you've done. What you see in the home is not what you see in the clinic most of the time.
That's right. You just don't get a full picture of the full dynamic. I mean,
Right.
and rightfully so. I mean,
Yeah.
the clinic's just not designed for that. It's at no fault of anyone.
No.
But I always say, when you walk in the door of someone's home, there's just 100 questions you don't have to ask.
Yes.
Because you already know.
Yes. And you can be polite in the moment and just you get a full picture of what's going on.
Right.
Yeah, pretty quickly. So we're going to do a comprehensive assessment. That's one of the domains we do. And we do this yearly. So we do it at the time of the beginning of service, which is going to be within the first 60 days that we're working with the patient and their family member. And then we're going to do it annually. It may even need to happen if there's been a change, like, a hospitalization or something like that, because their level of dementia might have changed based on an event. Then we are required to do person-centered care plans, which is really cool. So we're going to dive deep into what are those needs, what do they need ongoing, what does the caregiver need?
Yep. Not just the patient. So, which is really exciting to be able to involve the caregiver into that care planning.
Absolutely. And that's our excuse me, I'm getting tongue-tied. That's our opportunity to give these families the emergency checklist that they need to do for both of them. How to prepare for an emergency, when to call 911, when to call, us. More importantly, here's where your loved one is.
Yep.
We're going to be using a lot of Teepa Snow's positive approach to care and her gems. Where does Mr. Smith fall?
Yeah.
Mr. Smith right now is an emerald, and we can teach the family about what that is. And, when he's supportive, he might look more like a diamond, but if he's stressed or things like that, he could look more like an amber, and just talk to them about that and where he is. And then as we're listening to the family caregiver and we're observing in the home, we may recognize some things that are tips and tricks that we can send that family caregiver, whether it's TIPA's 10-minute videos. There's one I circulated yesterday, and we actually put it out on our social media, and TIPA's group uses, they reference her. There's a lady named Adria Thompson. She's a speech pathologist, and she's younger, but I'm excited where she is. Her Instagram page is Be Light Care. So BE Light Care. Okay. Adria Thompson, but she's got cool little 2 or 3 minute videos.
Oh, that's awesome.
So, if we're working with a family that has access to social media or has a grandchild that has access to social media or whatever, we can send those
great
things.
Resource.
Yes. And it's, to me, reading something doesn't always help me. I'm more tactile. So looking and hearing kind of the whole picture is good.
Well, and if you have a heavy caregiver burden, sitting down to read an article, it's just not going to happen.
No.
It's not going to happen.
No.
And if high stress situations, you just can't it's just not. So 1 to 2 minute videos are perfect.
Yep. Just real quick.
Yep.
Here's a tip, helping her get in and out of the car, or whether it's getting out of a shower or getting her to shower.
Sure.
All those things. And then, so with that care plan, that's going to tell us where we're going to direct their resources. Do you need to send them to a specialist for some reason, something other than dementia?
Sure.
We're going to coordinate back with and so one of the domains is care coordination and transitional care management.
Yep.
So talk to us about what that is.
Yeah. So I think one thing about our team is that we all bring such a wide array of experience, and we're already kind of combining some of those resources and knowledge that we have to be able to help patients quickly, because we're going to be covering a larger area than we have historically, which is wonderful. So care coordination is really about, coordinating all the aspects of that patient's care. So not just medical care, but mental health care, food resources, transportation, housing, all of those things that we know.
Helping to pay for utilities.
Gosh, I know. Without, you have to have all of those things to truly have adequate health care.
Right.
And so, we're anticipating that we're going to be serving some patients and caregivers who have a wide variety of needs and complex needs, and we're prepared to help tackle that.
Absolutely.
And so that will be involved in a lot of what we do.
Yep.
And then transitional care management, a lot of around transitions of care, so hospitalizations, ER visits. Oftentimes patients like this will get stuck in the cycle of hospital, rehab, home, hospital, rehab, home. I've seen it happen many, many times, especially with traditional Medicare patients. Yeah. And so really trying to have some protocols in place where we wrap additional support around those patients and caregivers after a hospitalization or ER visit my goal would be to help keep them at home, because we know dementia patients do better in areas that they're familiar with. 100%. So when we can keep them at home and engage additional services and keep them from returning to the emergency room unnecessarily, then that's what we're going to do.
Then we've done our job.
That's
absolutely. Right. So when you go through these domains, we've got the assessment, the care plan. We will have 24/7 access to us. So we have an on-call system all the time. Ongoing monitoring and support. That's, the monthly phone calls they're going to get from one of our care navigators, making sure that we're going through the care plan, or transitioning, like you said, into care coordination and transitional care management, referring and coordinating services and supports. That also includes us getting connected in the communities where we're serving. And one of the things we put in our application is the importance of faith-based communities in our southern state of Alabama.
Yeah, absolutely.
And that's going to look very similar in Mississippi, Tennessee, Alabama, Panhandle of Florida. A lot of where most people in rural settings, and even just smaller city settings, if you will, they get their support and resources typically from, their church, their synagogue, their wherever they go, on the weekends to have support. And it's important that we connect with them.
Yeah.
We connect with those faith-based leaders. We, if they need help developing a support group, we can do that.
Absolutely.
So, but it may not be necessarily in a faith-based organization. Like in Opelika, we are in a sports complex.
Yeah.
And so finding those areas that people feel comfortable coming to get support.
That's right.
Is super important.
Absolutely. Absolutely.
Of course, medication management and reconciliation. People are going to think that that's a common thing. Now, it was common for you.
Yeah.
Because yes, Shayla, you're special and unique.
Yeah.
And you did look outside the box and think holistically. But so many times, we saw this the other day. So many times, either they don't have any, they have no physician, or they have too many physicians.
Oh gosh, yeah.
What did you say the other day?
I said having too many physicians is equally as bad as having zero. It's the same.
That's right.
Because
you said having 10 physicians is like having 9.
It's nothing's actually happening when you have 10.
Right.
I mean, because it can't. It's not at the fault of those providers.
No.
So,
but here is a little tidbit for everybody out there. Most clinics, multiple clinics aren't talking to each other.
No, they're just not.
Unless you're under one umbrella.
Right.
Right.
That's right.
Because then they're all sharing the same
Directly.
electronic medical record
Right.
system and stuff
That's
like
right.
that. But other than that,
if you're seeing providers at different health systems or in different states, they're not talking to each other.
Right.
They don't know.
and this is one of the requirements for Guide, is showing that we are communicating back with their primary care physicians, the specialists, all of those things. They need to see what's going on. And then helping train those family caregivers or the person that's responsible for taking the person with dementia to the doctor. Tell them about this. Take this medication list. Tell them that these things have changed.
Right.
So another domain, caregiver education and support. This is huge. Like we've talked about, do we need to start a support group? I feel like most of what we're going to be doing is that.
Yeah, I think so too.
That ongoing resource where they thought they needed to call the doctor, and the doctor is usually like, I don't know what to do in that situation.
Right. That's right.
Now we can listen to them, hear what's going on, and provide a resource, or at least direct them in the right direction. To help them.
Absolutely. Absolutely.
Which I think is great. And then the domain that we are outsourcing, because we just don't do this domain.
And we're really excited about this one.
We're super excited about this one. Is the respite services.
Yeah, it's awesome.
So if you have a family caregiver, if it's determined in that alignment process in the beginning that there's a family caregiver that would benefit from this, and that really truly is the family caregiver that needs this kind of service, up to $2,500 a year is provided to that family for respite.
Yeah.
Think about this. That's 1 day a week for the entire year that someone could go to an adult daycare.
I know. That's incredible.
Huge.
That's incredible. And one thing that's really exciting about this benefit is that there hasn't been a benefit for respite unless you've been in hospice. And that typically looks like a patient going to a skilled nursing facility for a set amount of time every so often that's available to them, which is a wonderful benefit and certainly gives caregivers. But we're also that benefit's not coming until patients are in very advanced stages of dementia. Right. And then there's also typically they can only go to a facility. It can't, the care can't be provided in their home or through a, adult care facility. So I think it's going to give us a really great opportunity to meet the patient and the caregiver where they're at and provide the resources that are tailored to them.
Absolutely. So. I might try to qualify for that for my dog who just interrupted us and needs some
absolute-
respite services.
And she's absolutely fine, and she lives here.
But no, exactly. I mean, it's just a huge, I keep saying huge. It's a great opportunity for people to see. I mean, $2,500 in the scheme of things, when you look at everything that medicine pays for and you're running all these crazy, tests or emergency room visits.
Right.
Think about if the caregiver could get a break and the person living with dementia could go have a fun, enjoyable social day.
Yep.
Those kinds of things can go a long way to hopefully reduce those other hospitalizations.
Absolutely.
And then, because we've got resources across the state, there may be opportunities for us to plug into a daycare or a respite or Alzheimer's of Central Alabama, our wonderful friends at ACA that have scholarships where the $2,500 can go so far, but then if they meet that criteria, they could have additional.
That's right.
So it's just an opportunity to just open up the resources that are available to them.
That's right.
Which is exciting.
It is.
So those are the main 9 domains. I'm going to kind of go back through them. From the very beginning, comprehensive assessment. We're going to have a person-centered care plan. Of course, they have access to us 24/7, ongoing monitoring and support, care coordination and transitional care management, as I about knock over my mic here. Referral and coordination of services and supports, medication management, reconciliation, caregiver education and support, and our favorite, respite services.
Yeah.
It's a lot to unpack.
It's a lot.
So in all of this, except for some medication reconciliation, it wasn't send me to the lab or send me this prescription.
Right.
It's all things that are done from an environmental standpoint, a behavioral standpoint, in a supportive manner.
Yep. Just common sense.
Common sense. I love it. I love it. So y'all will be hearing a lot about Guide through the next year as we unpack and unravel this whole thing. We're really excited. What we do in July, now the core of what we do is always going to stay the same.
Absolutely.
But the systems of what we put together in July may change over the month or
They
so
will.
or 18 months,
And
just
that's
like
okay.
Amy said at Emory. I love the spaghetti effect. Everybody in the office knows I use this analogy. I throw spaghetti on the wall, and what sticks in the moment, we're going to go down there, and sometimes we may have to adjust it and
That's right.
throw more pasta on the wall.
We can pivot. We've done it before.
That's right. Well, that's the key to dementia care, to be honest with you.
Yeah, certainly.
It's not rigid.
No.
It's
No.
not black and white.
No, never. Never, never. No.
As I say, it's organic. when we meet with families now and present their plan of care, sometimes, particularly if you're working with like an engineer or somebody like that, they're like, I must follow this plan. And I go, I know I've presented this wonderful plan to you, but we may not use any of it. We may use all of it. We may use some now and ditch something later. And they
Yep.
look at me.
And that's okay.
And that's okay. That's
Yep.
right. Teaching flexibility. Maybe that's going to be my resolution.
That's a really good one.
I do need to work on my flexibility.
It's not like
Not-
innate
not-
to human nature to be just flexible. I
Right.
think we have to.
And I mean, I'm pretty
Bend
flexible in
ourselves to
like
it.
daily life, but I mean
Yeah.
like touching my toes and things like that. I think I'm going to, like, when I say flexibility,
Oh, you
Shaylee,
mean like physically
I'm talking
flexible.
about physical flexibility.
That is also important.
Yes.
Yeah.
That could be a whole nother program on how to like prevent falls.
Oh,
As we
oh
get
my
older.
gosh. We could talk about that for a long
Yes.
time.
Okay, I think I'm going to wrap it up, circle back around to where we started. I think that my goal for the New Year's resolution is physical and emotional and mental flexibility.
I love that.
Alan's going to be cheering because he's hoping that means that I won't go code red. So I'm going to end on this.
Well.
When we were doing the self-care last week, we were talking about the things to care for yourself, right? And I realized that I'd had enough perimenopause code red moments in the past week or two that I brought self-care as to saying I'm apologizing to my family. That's not caring for myself. That's just preventing an issue. So I'm going to be flexible this year.
There we go.
All right. Maybe Alan
Perfect.
will applaud that one. All right. Well, thank you, everybody. If
Thank you.
Hopefully you enjoyed our flexible
It was very flexible.
conversation about Guide. More to come. Again, this program for us starts July of 2025. So we will be doing a big push over the next 6 months. And then we will start seeing patients officially for Guide July 1 of 2025. Super exciting. More to come. And anyway, please, I hope you liked it. Follow, like, subscribe. We're on Spotify, YouTube, Apple Podcast. I think I covered all the things. And anyway, we'll also be going over the last several podcasts, finding our jewels that are tucked into all of these conversations, so
I
that
love
we'll
that.
have more to
That's awesome.
leave as a resource.
Yeah, that's great.
So anyway, thank you for having my co-host Shaylee today, and I'm going to sign off there. Thank you.
Thanks.